And I'll go ahead.
It's like, hi, welcome back. We're pivoting away from 583 to 585, and we have Dr. Will Everett in, and he wanted specifically to speak on, I believe, one of the sections or a couple of the sections maybe that are in the bill. So happy to have you in, and thank you so much for joining us. You can go ahead.
Good morning to the chair and committee. Thank you so much for having me. And again, if your schedule at all accommodated mine, I do very much appreciate that for this opportunity. I just mentioned I'm Dr. Will Everett. I am a family physician and hospitalist at Grace Cottage Family Health and Hospital, which is the rural health clinic and critical access hospital down in Townsend, Vermont. I currently serve as the medical director here, as well as the medical staff president, and I'm the president-elect for the Vermont chapter of the Academy of Family Physicians. To my understanding, as you just mentioned, yes, specifically I've been asked and or directing my my testimony towards section 11 of H585 to provide further context about prior authorizations and the possible impact of the suggested verbiage of the bill. And this is something, unfortunately, that pretty much all primary care providers have too much experience with. The definition of a prior authorization is really pretty straightforward. It's the idea that an insurance company states that before they will approve or commit to paying for a service, that they need further evidence that the service is warranted. Given the ubiquity of this, it's become standard practice for really any healthcare entity that they will ensure this step, meaning the prior authorization, is completed before actually offering the service to a patient, in order to avoid passing the cost to the patient and then running into a much greater risk of it not being reimbursed. While in principle, this relatively straightforward process or practice does make some amount of sense, the numerous services that prior authorizations are applied to and the administrative burden make an enormous administrative burden, and the design of the system consistently leads to delays in care. For perspective, and again, I apologize, my testimony is not written ahead of time. I will get it to you all. A recent KFF poll showed that 47% of insured adults had a delay in or denial of medication service or treatment within the past 2 years, and that 69% of insured adults find that prior authorizations are at least some amount burdensome, which was greater than any other aspect or possible burden that they felt related to their healthcare. This legislation specifically is talking about prior authorizations related to procedures or imaging studies, so I'll focus there. Recently, I had an opportunity to see a woman in her 50s. Just a few days before the appointment, she found herself on the ground, seemingly having passed out. She has no history of heart or metabolic or neurologic disease that this would be common for her. We would expect it. She found it to be a very odd experience, but she felt completely normal when she got up, and so she didn't feel like she needed to be evaluated emergently. She saw me a couple of days later, and we reviewed the experience, what she was feeling, what was going on. There was no signs of any active disease. There was no evidence of any recurrence or further preceding symptoms, which was quite reassuring, but it is still generally concerning when a fairly darn healthy human suddenly collapsed without an explanation. My concern, or one of my concerns at the time, is that she was experiencing a heart arrhythmia, which is an abnormal rhythm of the heart that can come and go, but when it is there, and sometimes that's without symptoms or trigger, it can cause her to pass out. The tool that I have immediately in the office is an EKG, which is 10 seconds of heart monitoring. And very unsurprisingly, it was normal. She wasn't having any symptoms at the time and was feeling just fine. What would be very helpful in that situation, what is very helpful in that situation, is something called a Zio patch. This is a sticker that goes on someone's chest, and it sits there for 14 days. And during that 14 days, it constantly monitors someone's heart rhythm. So it provides much more context about what someone's heart is actually doing over a period of time. We have a number of these, meaning the Zio patches, sitting right down the hall from my office. The patient was in full agreement with the plan, given the concern about the episode, as well as some family history of heart disease. But the test required a prior authorization based on her insurance. So instead of me simply walking down the hall, putting the sticker on, and then getting results, basically 16 days later, we sent the order to the insurance company and waited for the response. Depending on the insurance company, this can take quite some time, days, to get back to us. This was a patient who recently collapsed, has a decent risk for recurrent symptoms or a more concerning situation, and I couldn't initiate the test to help figure out what was going on while she was literally sitting in front of me in the office. Unfortunately, like many folks, this is a human who is working, and her paychecks are very important to her livelihood on a week-to-week and month-to-month basis, and she has to take off work to come to the office, which creates a lot of logistical and financial stress. She ended up having to come back 4 days later, again missing part of a day of work to get the patch placed, because that is how long it took to get the prior authorization for the test. I will share another example. It is also quite common that patients arrive to my office with some version of abdominal pain. This can be quite variable, but about a month ago, I saw Mike, who's a patient I've been seeing for a while. He came in with his wife, and for 2 days, he was getting quite a bit more lower abdominal pain to the point that he wasn't really hungry anymore. He didn't have a fever. He wasn't sick in some way. He has no history of abdominal surgeries. His vitals were lovely. The only things that were abnormal is he looked pretty darn uncomfortable. And then when I pressed my hand to the right lower part of his abdomen and let go abruptly, he exclaimed in quite a bit of pain. By definition, this is called rebound tenderness, and it made me quite concerned that there was an active infection in his belly. There certainly are much less concerning things that could be causing that, but I can't rule those out without further testing. And the testing that's really important there is a CT scan. As I mentioned in my introduction, I work at Grace Cottage, and what I love working at a small hospital-based practice is up a single flight of stairs or elevator ride. There is what many of us consider quite basic medical tools, including a CT scanner. If I was working somewhere else or a more isolated practice that I couldn't coordinate this in a timely manner, I would have to send him to the emergency room because realistically, that would be the only option in terms of getting a timely CT scan. Instead, I walked right down the hall to our patient coordinator's office. I reviewed the situation. They opened up the online portal for our patient's insurance, and within minutes of inputting the appropriate information, we had a prior authorization that said that we could proceed with that. We gave him a ride upstairs, and I got a call from a radiologist 30 minutes later that he had appendicitis. I called the local surgeon in Brattleboro, and we successfully coordinated his care in a timely manner without a prolonged ED stay. If he had gone to the emergency room at Grace Cottage, we do not have a surgeon on site, so he would have required an ambulance transfer to any other facility that had a surgeon to then have another ED visit and potential intervention at that time. To me, especially the Mike example, emphasizes the role of prior authorizations really as simple administrative burdens. In his example, as was, I think, clear, there was no thorough review of the medical record on the other end. There was no suggestion of other treatment or evaluation options. We literally ensured that the correct box was checked for, quote, abdominal pain, and then we were allowed to proceed. It, in that case, happened really fast. In other cases, it doesn't. I feel that Mike's example also illustrates the financial burden on healthcare entities to engage in the prior authorization process. Very few providers that I'm aware of actually engage in this process themselves, meaning the processing of the paperwork or the clicking the buttons, unless sort of the final stage of it is a verbal appeal with a quote unquote medical specialist with an insurance company. Who actually does this are hired administrative staff. So for perspective, in our small institution, we have less than 10 full-time equivalent clinical providers. We have one full-time administrative staff just to cover the medication prior auths, and then we have 2 full-time patient coordinators that handle all of our referrals and then the prior authorizations for procedures and imaging studies. And as I was reviewing this bill and sort of thinking about healthcare costs in general, this is something I come back to a lot, imagining if we scaled this model as it is to bigger clinics and bigger hospitals and the amount of administrative burden and cost that goes along with processing these. I really do appreciate the verbiage in H585 limiting prior authorization exemptions to independent practices with what I would hope would be the goal of minimizing all administrative burdens to smaller and perhaps less resource practices. In my opinion, it is missing an opportunity to allow all Vermonters to access timely testing and treatment, no matter where they happen to access care. Grace Cottage is a hospital-based practice, and we are quite literally in the middle of nowhere. We are the resource in the area. And with the numerous barriers to transportation in our state, many Vermonters don't have the opportunity or ability to shop around for healthcare based on price or any other factor, even if it was more readily available. And in many cases, they wouldn't want to. You know, the notion of a medical home and continuity of care is really important to many in our communities, and they often feel strongly about keeping their care local. Reducing the prior authorization burden for all practices, including hospital-based practices, only reduces the administrative burden and costs for a clinic or hospital and increases the efficiency of appropriate medical care. There are multiple avenues being explored in our state to minimize the administrative costs of healthcare and to improve access, accessibility, and the timeliness of care. I really do feel that minimizing prior authorizations are a clear opportunity to further all of these goals. Thank you all for your time today.
Thank you. Topper has a question, but I have a question first.
Your prerogative.
I'll do my best.
First of all, I appreciate your testimony. I so strongly agree with you that a year ago, we did Act 111, which starting January 1st of 2025, if you are a primary care physician, you no longer have to do prior authorizations, except for medications, I think. It doesn't cover meds. So I'm sorry, I can't do anything about those. However, I'm wondering why you did prior authorizations on either of these two people, because both Zio patch and CT scan would have exempted you from having to do that, unless, of course, their insurance is one that we don't. So I'm wondering if.
Certainly. The very appropriate question is the question that I had myself and have continued over the last year. I know I've not testified before. I'm newer to this process. But I was aware of that bill through the Academy of Family Physicians, and in full support of it. When talking to our patient care coordinators preparing for this, they're the ones who process. I asked that same question. The simple answer is it did not all magically go away, and that's going to be a very unsatisfying answer. Because I am clear what the bill showed, but prior authorizations still are at play in a number of scenarios. For these specific pieces, it could be related to the insurance that they certainly it would be related to the insurance that they had. But I still think that they emphasize, even if I perhaps misplaced the insurance that these specific patients were on, it emphasizes the clear burden of the prior authorization process. And as a hospital-based practice, this is exactly what it would go back to, if not persist as, if the verbiage in the bill remains the same.
Yeah, great, thank you. Topper, did you?
Yep.
And then Leslie.
Let's say you have 10 tests that you want to perform.
Okay.
And all of them, and just use the experience you've had in this last year. How many of those prior authorization requests have been approved?
Thanks for that question. I had about 4 days heads up for this. I specifically wanted to try and get internal data for us regarding that. I apologize, I don't have an exact number. I'll try and provide it in my written testimony. What is my impression of that? Again, having reviewed specifically with our patient care coordinators in the last couple of days, is it can be quite variable. What is my answer yesterday and today to that is, my patient care coordinators are saying it's about 50-50 right now.
Really?
Yeah.
Thank you.
And I know this is not in reference to medications. I'm not trying to make it about that. Just for context, though, that number is, the number of denials and or delay is dramatically higher. My initial comment that this is something that is ingrained in us from the moment we start down a primary care path is very true.
Thank you.
Leslie.
Thank you for the question.
Thank you for your testimony very much. I am from your area, so I'm very familiar with Grace Cottage.
Great.
One of the other previous witnesses said there was a concern that specialists were going to run prior auths through who work in a hospital system through their primary care colleagues rather than do it themselves. So and that was one of the reasons why they wanted to carve out this independent practice to to stop that practice, I guess. Now, I don't imagine you have a lot of experience with specialists in that way, but I was just wondering through your experience and work, is that something that's is a worry to you? Do you see that as a realistic concern?
Thank you for the question, and I appreciate the disclaimer that I may not have full context there. We do not have any specific specialists on staff at Grace Cottage. I will lean on, I am 3 years out of residency training. I did my training at UVM, so a much different system than Grace Cottage. My experience there or in reviewing with colleagues is, I mean, to be fair, where my mind goes is it's not the providers who are doing this process. It's administrative staff. So whether it's administrative staff via, their title is under a primary care office versus under a hospital specialist group, it is the idea of administrative staff are being hired to then to do this work. It's already part of practice, not infrequently, that specialists will defer, and I don't mean that in terms of delay. I mean defer things back to primary care providers. For example, here we have a small pharmacy semi-associated with us. If I prescribe for certain insurances, if I prescribe medications for patients, it ends up being cheaper at the pharmacy than if a specialist prescribes the exact same medication to patients. Again, not trying to emphasize the medication pieces, but just to clarify that in our complex system, there are numerous examples where things sort of fall back on primary care. To me, the emphasis is really on the need for the administrative staff and therefore the associated cost and burden that goes along with it, whether it's housed in a specialist group or in independent practice. If I'm understanding the question correctly, that further makes sense to carve out independent practices if they don't have the bandwidth for further administrative staff, so more tasks and being put on them. I think we could potentially stick with the verbiage from last year to say, is this process actually really necessary for quality care for Vermonters?
If I could, so what I'm hearing, and I'm sorry if my question is a bit inarticulate, but
it's okay.
So do you imagine that if a primary care, specialty physician wanted a PA and wanted to run it through primary care, that they might not actually have the primary care clinician touch that PA and it go all through administrative land? Or would a primary care person have to be involved?
Let me try and talk through what I potentially think would happen with that. So I am not aware of a mechanism where, and I'll speak to being here in Townsend, where an outside provider not on staff at Grace Cottage, a specialist, would send an order that then our administrative staff would have to do the prior auth for, that. I do not think there's a mechanism for that piece of it. I suppose so how would that process work? I could be contacted either via a medical note or a message from an outside provider, a specialist, that they would recommend that I order X, Y, or Z testing. And if I am the one that orders it, I and my staff are responsible for whatever, paperwork and or approval are associated along those lines. I think in general in primary care and in medicine as a whole really do work to be collaborative. That is not over the, I think I would say there's many steps between the standard of care and sort of who handles what, and then sort of like me being told what to order by other providers. At the very least is I would be the one getting the results. And if I'm not the one that should be interpreting results, the specialist should be. It just creates a delay in care about what's going on. They're the ones evaluating the patient, the patients and the concern. Does that attempt to address your question?
Yeah, I mean, I think I'm understanding it better. I don't want to belabor it, but it is an issue about taking out this section. And I think that's what you're asking, right? For us to remove that new language.
That's what would make sense to me, is to remove the language. Yes. I think to answer your question, from being inside the system, I I don't see how the authorization process would change or otherwise, whether it's specialists or primary care. That would be a big shift in the standard of care and the appropriate ordering of tests based on the providers actually assessing the patient and determining what testing is appropriate. I would also further, to be totally fair, I have somewhat emphasized that I don't find the prior authorization really in any way to improve a patient's care. I find that it delays, it limits treatment options a fair amount of the time. So whether it's a specialist that's running the prior authorization or a primary care that's running the prior authorization, if we are aiming to provide high quality care in a timely manner, prior authorizations get in the way of that.
Thank you. That actually leads me sort of to my question, which you have answered, but so Act 111 has been in effect since January 1st of 2025. The prior authorization piece has, for physicians practicing just primary care physicians, doesn't matter if they practice in the community, in the FQHC, within a hospital, it applies to everyone. This bill is contemplating that we exempt hospital employed primary care providers from the exemption. And I'm wondering, we don't have a report due until next year. So we don't have any data on this, but anecdotally, since this has been in effect for 1 year, do you feel as though you've changed your practice of medicine and you're ordering a lot more tests than you used to?
Not in any way whatsoever.
Okay. Thank you.
Let's get that on the record.
Let's get that on the record. Any other questions for Dr. Everett? Okay, thank you. Thank you so much for sharing your perspective on this.
Thank you very much for your time. I do appreciate it.
Thank you. All right, done for the morning. We can go off the live. We'll be back at 1 o'clock.